I'm Dr. Ronnie Smalling, cardiologist at Smalling Vascular Institute in Overland Park, Kansas. I would like to thank Dr. Craig Walker for inviting me to participate in the NCBH Digital Education Series. It's a great pleasure for the invitation. Tonight, I'm going to discuss recap of this year's best venous trials. I have no disclosures. I have no conflicts of interest. A recap of 2019-2020 year's best venous trials. Over the past year, there have been more studies on venous reflux compared to other years. Numerous studies, including many more late-stage disease patients, have been performed. Many trials reveal evidence that we are losing the battle, demonstrating to payers, patients, our colleagues, and how debilitating chronic venous insufficiency, or CVI, is to how we must improve total healthcare costs and outcomes with more treatment. Trials in order of importance. I'm going to discuss study number 1, EVRA trial, the EVER trial, a randomized trial of early intravenous ablation and venous leg ulceration. Study number 2, cost-effective analysis of the EVER trial of the early versus deferred intravenous ablation treatment of superficial venous reflux in patients with venous leg ulcers. Study number 3, treatment of superficial and perforator reflux and deep venous stenosis improves healing of chronic venous leg ulcers. And study number 4, the clinical characteristics of lower extremity lymphedema in 440 patients. Dr. Marlon Schull, the current president of the American Vein and Lymphatic. In Dr. Marlon Schull's presidential address at the 2019 American Vein and Lymphatic Society Annual Congress, he discussed the undertreatment of venous disease, a novel concept. As per Improving Wisely data by the AVLS, nearly 3,582 Medicare beneficiaries with venous ulcers were treated with thermal ablation, while 7,418 with the diagnosis of venous leg ulcers received no treatment. Dr. Schull explained the importance and need of undertreatment of venous leg ulcers despite the overall present concern on overtreatment. And I also talk about some new guidelines that we need to build more benchmarks. 3 consistent studies indicating median interventional rate of 1.6 to 1.7 ablations per patient. Multi-societal initiatives, increase access to care. Easily there could be 200 patients per doctor. Increase in provider confidence, and payer perceptions must change. In the EVER trial, a randomized trial of early intravenous ablation and venous ulceration by Goyle et al. In 2018 revealed a conclusion. Early intravenous ablation of superficial venous reflux resulted in faster healing of venous leg ulcers and more time free from ulcers than deferred intravenous ablation in patients who are newly presented to wound clinic. And this is a UK trial. Hypothesis was that there's no difference in ulcer healing between early and late interventional groups. The early group, after randomized in 2 weeks, they underwent evaluation of the leg veins, and if they were insufficient, they were ablated. The deferred group was the group that was deferred for at least 6 months before they were eligible to undergo venous ablation. Outcome assessment, there was primary and secondary objectives. In this graph, we see that the cumulative healing rate was much faster and higher in the early intervention rather than the graph on the lower part, which showed the deferred intervention. It shows the different time number of patients. Initially, in the early intervention, 223 patients, and the deferred, 225 patients. And then the 60-day, 120-day, all the way out to 360 days. The median time to ulcer healing was 56 days compared to 82 days in the deferred intervention group. Relatively more patients had their ulcers healed in the early intervention, and the rate of ulcer healing at 24 weeks was 85% compared to 76% in the deferred intervention group. The rate of ulcer recurrence was lower by 0.08 events per person year, And there was longer ulcer-free time, 306 days, as compared to 278 days in deferred intervention group. Now, study number 2, treatment of superficial and perforated reflux and deep venous stenosis improves healing of chronic leg ulcers. This is by Peter Lawrence and group, Journal of Vascular Surgery, just recently published, 2020, evaluated the impact of these 3 modalities and how they had a cumulative effect on ulcer healing. It's found that ablation of truncal and perforating vein reflux and stenting of deep vein stenosis with balloons and stents all contribute to healing of chronic venous ulcers. Thus, a patient with a chronic venous leg ulcer, or VLU, should have truncal reflux in incompetent perforating veins treated to improve wound healing. Patients who fail to heal after superficial and perforated vein treatment should have ultrasound of the iliofemoral system interrogated with either MRI or CT venography for a diagnosis of significant stenosis. And that can be further treated with deep vein stenting. Patients, in the conclusions, the patients with venous ulcers who failed compression therapy improve ulcer healing by ablation of incompetent superficial truncal or saphenous veins and perforating veins, and also stenting of deep vein stenosis. The addition of ablation of incompetent superficial veins to deep vein stenting further improves ulcer healing. Dr. Lawrence also described and defined some parameters of mild, moderate, and severity of the level of reflux. In other words, mild reflux was defined as either superficial or perforator or deep vein reflux. Moderate severity of venous reflux was defined as superficial and perforator or superficial and deep vein reflux. Severe was when we had superficial truncal reflux, perforated vein reflux, and deep vein reflux. The mean ulcer size for all patients was 5.5 plus or minus 7.1 centimeters squared. The study found ulcer size correlated with venous reflux affecting 1 or more levels, such that patients with the largest ulcers also had the most significant multi-level disease, multi-level being superficial, perforator, or deep vein reflux. Patients with venous incompetence of greater than 1 level had large ulcer, while patients with deep vein stenosis, as well as incompetence of 1 or more superficial veins, had the largest ulcers. It was found the impact of perforator ablation in combination with truncal ablation was most prominent for small and medium ulcers. This is a diagram showing the different groups. 832 patients, of which 187 on the left continued compression throughout the trial. And then there was 528 patients who had truncal vein ablation, and then if remapping indicated perforator vein reflux, the 344 patients in the perforator vein ablation was treated. Also, there was an arm of just perforator vein ablation by itself, which was only 22 patients. In looking at deep vein stenting, or iliofemoral stenosis in iliac vein compression, if you will, 195 patients were in that group. 95 patients were in that group. Of the 95, there were 44 who also had truncal vein ablation, and then 18 patients had all 3, truncal and perforator vein ablation with deep vein stenting. When you look at the results in the treatment arm, compression alone management, 50% of patients, the ulcer was healed after a median time of 15 months. These were small ulcers which healed more frequently. The recurrence rate of 15% at 24 months was noted on follow-up. Factors associated with ulcer recurrence were presence of superficial and perforator reflux and an ulcer size of between 5 to 10 centimeters squared. Truncal ablation treatment group. The frequency of ablation, there were 446 with greater saphenous vein ablation. Small saphenous vein ablation was 329, and anterior accessory saphenous vein 6. If you look at group C, perforator ablation in combination with truncal ablation treatment, Increased ulcer healing rate by 17%, which is baseline 51% plus additional 17% or 68%, if truncal and perforator ablation was done also. Impact was most prominent for small and medium-sized ulcers. So the larger the ulcer was, the more advanced disease, the more ablation was required, including the truncal saphenous veins and the perforator veins. Interestingly, age, sex, BMI class, and history of superficial vein thrombosis, or DVT, had no significant impact on ulcer healing. If you look at group D, the perforator ablation treatment group, median ulcer time was 27 months. In E, stenting of the deep vein iliofemoral area was noted in 5 patients with an ulcer healing rate of 75%. If you look at the method of treatment, number of patients, 95 patients had deep vein stenting, and that was the ulcer was healed in 3.3 months. Group 2, deep vein stenting with truncal vein ablation, saphenous vein, 48 patients with a healing time median of 3.6 months. Now, in the deep vein stenting and truncal vein reflux ablation, perforated vein reflux ablation, there were 18 patients, and the healing time was 6.7 months. It's felt it was longer because these patients had more complex and more advanced vein disease, but they did heal in 6.7 months and not in 36 months, as in some of the other studies. Median ulcer healing time for patients in deep vein stenting and venous ablation was cumulative treatment modalities. If you look at this graph, patients with deep vein stenosis, significant healing benefit was seen in patients with stenting compared to conservative compression therapy. The deep vein stenting is in the red bar, and the blue bar was conservative treatment. If you look at deep vein stenting versus truncal vein ablation, perforated vein ablation, or deep vein reflux, there you can see that the lowest and the slowest healing rate was in the conservative compression group. And the patients with the fastest were in combination of superficial and perforated vein reflux ablation with deep vein stenting. This slide shows intravenous ablation of competent perforating veins as effective treatment for recalcitrant venous ulcers. Once again, Dr. Peter F. Lawrence and his group in the Journal of Vascular Surgery in 2011 reported that 57 ulcers with 86 incompetent perforated veins were treated with perforator ablation. It was found that the technical success ablation occurred in 58% of initial procedures and increased to 90% with repeat perforator vein ablations. In patients with successful ablations, 90% of ulcers ultimately healed. Additionally, the study demonstrated that a subgroup of patients with recalcitrant non-healing ulcers, very difficult to heal, which did not heal despite optimal compression and ablation of refluxing veins, benefited from perforator ablation. This is, apologize for the slide, it may not show up quite as good as my other slides, but this is Handler, Locke, and all, who's working with Dr. Lawrence in the Journal of Vascular Surgery, demonstrated improvement in venous leg ulcer healing rates after ablation of refluxing truncal veins and perforated veins, with 82% perforated vein closure, 76% of the ulcers healed at a median of 142 days, roughly 6 months, with a recurrence rate of only 7% at a mean of 12 months of follow-up. Another trial looking at wound healing is from Yi in April of 2012 in the Journal of Interventional Radiology. This study, in April 2020, reported ulcer healing rate of 82% in patients with non-thrombotic iliac compressive lesions, stenosis, which correlates with the Lawrence study, wherein patients who underwent stenting and concomitant and competent vein ablation had an ulcer healing rate of 88%. we see a dramatic increase in healing rates when multiple beds, multiple levels of venous ablation is performed. This is from the Journal of Vascular Surgery from May 2020, where Marston reported the incidence and risk factors of deep vein stenosis in patients with active and healing venous ulcers. The conclusions found that deep vein reflux patients were 18 times more likely to have iliofemoral stenosis, and 77% had greater than an 80% iliofemoral stenosis, and noted early that nearly 1/3 of lower limb with active ulceration had an iliofemoral stenosis of greater than 80%. Saying that another way, it's that patients with severe iliofemoral stenosis of 80%, only 1/3 of the lower limbs healed and required more aggressive treatment. Study number 3, and this is a very important study, cost-effective analysis of EVER trial versus early versus deferred intravenous treatment of superficial venous reflux in patients with venous leg ulcers. It's easy to see that early versus deferred venous ablation led to earlier leg ulcer healing, but what was the benefit of that more than just clinically? How was it affected the cost and the economics? The conclusion is that early intravenous intervention is likely to be cost-effective with an 89% probability at a threshold of 20,000 pounds for a quality-adjusted life year. UK has determined that a cost of 20,000 to 30,000 pounds would be an advantage and be cost-effective in patients in the UK. This slide shows the economics and costs of the 2 treatment arms in the EVER trial. The deferred group on the left, the early ablation group on the right. If you can see at the top, the costs are essentially the same. 2,516 pounds for the deferred group, 2,514 pounds for the early intervention. What we notice at the bottom in the light blue and the black bars, on the left, the overall cost for the deferred ablation, those that had to wait 6 months before they could be treated, was lower than the early interventional group, as would be expected. However, if you look at the cost of primary and community care, the black segment of the costs, on the left, the early intervention, they had much more expenses in follow-up and treatments and such things as that. On the right, the costs were less. Hence, early intervention resulted in more costs, but those costs offset the higher costs in the deferred group. So you got early intervention, earlier healing at the same cost as those patients who were deferred. Primary outcome was quality adjusted life years at 1 year, estimated for each patient using data collected from EQ5D questionnaire completed by patients at baseline, 6 weeks, 6 months, and 1 year after randomization. As we stated, the total cost per patient, resources, and use items reported at monthly follow-up by telephone call for each patient, non-ulcer related healthcare and out-of-pocket expenses, and time loss from usual activities tabulated but were not included in the total cost per patient. The total cost per patient over 1 year was similar in the 2 groups as mentioned. Earlier ablation group did have a greater initial cost due to allocated venous ablation procedure, but it was later compensated by lower costs of district nursing homes and visits to quicker wound healing. Due to quicker earlier ablation group did have a greater initial cost due to allocated intravenous ablation procedure, but it was later compensated by lower costs of district nursing home visits due to quicker wound healing. This looks at the economics in the different groups that we have classified, M1, M2, M3, M4, and we looked at different ways of costs versus their effectiveness. In the deferred population, 55 of 226 patients received no intervention, compared with 7 of 224 in the early intervention group. Another way of looking at that, in the deferred group, 55 patients refused or did not choose to have a procedure for venous ablation, even though they had the opportunity. So of the 55 with no intervention in the deferred arm, 35 completed the study, of whom 26 had healed the ulcer within 1 year. As the study was conducted for only 1 year, the recurrence rate of ulcers was not looked at. In a complete case analysis, greater costs are the early intention group with mean costs favored the early intervention group. If we look at one of the newest and hottest topics, and that is iliofemoral stenting. Up until now, the use of the wall stent and the Z stent have been used primarily for iliac vein compression syndrome. However, there's been exciting development, and there are now 3 new stents available, FDA approved since 2019 and 2020. The endovascular venous stent reconstruction, feasibility with good clinical outcome and durable patency rates. It has become standard for chronic iliofemoral thrombosis to treat with lytics, but also address the underlying stenosis. The track trial revealed the study reported clinical success, good patency, and supported its use in a variety of clinical settings. IVC filter associated thrombus, as well as non-IVC filter related chronic iliofemoral thrombosis. Maybe retrospectively analyzed 406 patients to assess the safety and patency of lower extremity costs. We found that the new stents include the VISI, the Boston Scientific stent, FDA approved May 2nd, 2019, the Novo by BD International or Interventional, March 13th, 2019. More recently, the Abre by Medtronic, June 16th, 2020. These are FDA approved dedicated stents. Sinoacrylate closure appears to be safe for chronic venous insufficiency. 2 studies compared short and long-term outcomes of sinoacrylate closure, CAC, versus radiofrequency ablation for treatment of greater saphenous veins. The sinoacrylate in the United States is known as Venous by Medtronic. 12-month efficacy and complications of sinoacrylate embolization compared to RFA for greater saphenous veins were reported in the Journal of Vascular Surgery, Venous and Lymphatic Disease in 2019. Mean procedure duration for RFA was 45 minutes, and for sinoacrylate was 20 minutes, respectively, GSV. At 12 months post-procedure, 99.5% of the sinoacrylate group demonstrated complete occlusion or closure of the RFA, of the GSV, and 96.6% closure of the GSV by RFA. The RFA group reported relatively more side effects such as severe pain, ecchymoses, and sensitivity. 222 patients randomized, of which 171 completed the follow-up and included 87 from the sinoacrylate group and 84 from the RFA. For 24 months, the GSV closure rate in the sinoacrylate was 95% and 94% in the RFA. This demonstrated that sinoacrylate is safe and durable with similar and significant improvements in quality of life of patients through 24 months. I would like to touch briefly on the clinical characteristics of lower extremity lymphedema in 440 patients. This is very important. We have historically thought that the most common cause of lymphedema is due to cancer or cancer-related illness. However, of this 440 patients that was in a cancer clinic, found that chronic venous insufficiency, 41.8%, not cancer, which was 33.9%, is the most common cause of lower extremity lymphedema in a large cohort of patients. In addition, it identified a heterogeneous causation of lymphedema, 1 in 4 patients. Historically, it's been thought that it was more one etiology. The long-standing premise, we said, most common cause of lymphedema is cancer, etiology attributed typically to a single or exclusive entity. There is a dearth of definitive studies comparing frequency and clinical characteristics of lower extremity lymphedema. This table basically shows the cancer patients and the causes of lymphedema. If you look at the cancer patients and cancer patients with CDI, it was 33.9% total. If you look at the total on the CDI group, CDI by itself was 34%. CDI in patients who had cancer therapy, and CDI and surgery was 4.3%. So the total of CDI causing lymphedema was 41.8%. Lymphedema with either cancer therapy or CDI, cancer therapy or CDI and surgery is 11%. Primary lymphedema was 12.5%, and that was reported in this recent article in 2020. The four principal diagnostic characteristics: chronic venous insufficiency, known as cerebral lymphedema. Then there's cancer-related lymphedema, CRLE, primary lymphedema, and lipedema with lymphedema. I would like to thank you for this opportunity to give this presentation today on some of the most interesting trials on chronic venous insufficiency and venous ablation, venous ulcers. Thank you very much.